right, welcome to step number 7, the big one we've all been waiting for in our 12 lead EKG interpretation. So this is a big section. Actually, probably the bulk of this lecture has been leading up towards it. So we're going to spend a bunch of time going through the basics just to get you to where you need to be to really understand and interpret these. We're going to go through just a quick A&P reminder. We're going to talk about the leads quite a bit and what you're going to expect. We're going to talk about what ischemia, injury, and infarction really do look like. So we're going to talk about an MI itself and how it affects the heart and what's going on. And then finally we'll get into interpreting the areas of the heart. After we get done with the areas of the heart, we'll do lots and lots of examples. There'll be quite a few of them. So please just look at the hyperlinks in the description so that you can bounce around the lecture and pick up where you left off, because I don't expect too many folks to get this done in a single setting. But here we go. So ischemia and injury are the early phases, and an infarct is the later part of any MI, myocardial infarction, and that is going to be differentiated by ischemia and injury, early and reversible. Whereas an infarct has resulted in permanent damage, actual cell death, which will result in scar tissue should the patient survive. That infarct also is that huge risk you have for remodeling, electrical issues, electrical conduction problems going forward, and potentially even rupture of the heart muscle itself, things of that nature. What an EKG does for us is if a patient presents with acute coronary syndrome symptoms, so they've got the chest pain, they've got the nausea, vomiting, that classic left arm pain, things of that nature, diaphoresis. If they present with those symptoms, we, for all intents and purposes, always assume it's always a heart attack until proven otherwise. And an EKG is really helpful in that. But it can only help so much. It's like any other test. It has caveats. But what we can get from the EKG is if we combine its information with duration. The EKG will help give us an idea of the size, so the scope, the amount of heart involved. It can give us a rough anatomic location, which coronary artery, essentially. Coronary artery. If we have a baseline to compare it to, that would be fantastic. Because if they've had an MI in the past, some of the changes that have occurred to their heart because of that may skew the results of what we're seeing now. So having a baseline is always nice. And then combining with the EKG, you have to have the biomarkers, the troponin and the CKMB, which again comes back to duration, because if it's early enough, your biomarkers aren't going to be where they need to be. So EKG is just one part of the overall evaluation approach. All right, so refresher, way back in the first lecture, or first section of this lecture, we talked about this stuff, so I'm just going to re-hit it again, but with a focus on MIs. So within your heart, your Purkinje system is near the endocardium. And for all intents and purposes, a lot of what we're going to talk about for the remainder here is going to be focused on the ventricles themselves. So your Purkinje system is going to lay here towards the endocardium, the inner part of the heart. And what's neat about that is your depolarization starts on the inside and moves out. And that's how you'd want it, right? You'd want that inner part of the heart to start contracting first and have that successively move outward. So endo, epi, and we'll make this our cardiac wall here, so myocardium. And what happens is the contraction will start in the inner part and just successively move outward towards the outside, which is really cool because that'll help squeeze blood out. So any venous blood gets pushed out. It also prevents the arteries from being pinched off at the outside and then sequentially squeezed inward, because then that forces blood into an area where it won't really fit well. That makes a lot of sense. What's really interesting, though, is your repolarization. So setting up for the next contraction occurs from the outside moving in. So your repolarization, which I'll make green, is actually going to go this direction from the outside moving back in. From everything you've ever been taught and thought about, everything goes from one end to the other. So if it depolarizes on one end, it's going to then repolarize from that same direction and move its way through. Well, what's really neat about the heart is because of the increased pressure on the endocardium, right after contraction, there's actually enough extra pressure to prevent the cells from doing their normal potassium and sodium exchange. And that's just related to the extra pressure from the squeezing. We're talking about fractions of a millisecond, but it's just enough to change the way things work, which is actually really cool. The next part to talk about is going to be delays and interruptions in this flow are pathologic. So we should always see, change my color back here. So a normal ventricular depolarization should look something like this with a nice T wave on it, correct? Well, anything that's different than this means that there has been a delay or an interruption to the flow of electricity. Common causes would be hypertrophy. Makes sense. You've got instead of a nice narrow muscle wall, you've got a thickened wall. Well, that's just going to take longer to depolarize. If you look in the upper right corner, it's going to take longer to depolarize because there's more space, and it will take longer to repolarize, which is why you wind up with our thing with our wide QRSs, which may have something like that. A bundle branch block, great example. Reduced or blocked blood flow will definitely affect that as well, because you need oxygen to be able to repolarize properly. And if you're not getting the oxygen you need, you're going to have you're going to have repolarization issues. And that's what we're really looking for when we're doing a 12 lead and thinking about MIs, because that lack of blood flow leads to a change in repolarization, and that's what can cause things like ST elevation or things like ST depression, flipped Q waves, etc. We'll talk more about those as time goes on. The last thing that'll throw you off is electrolytes, and we talked about this before as well, which can be your highly elevated potassiums, or extremely low for that matter, and other things like that. So, ST segment and T waves, which is going to be huge for looking at MIs, because your ST segment and your T waves represent repolarization. So if there's any changes to those, there's a problem with repolarization, which means that there's a problem with potentially blood flow. And that's where you overlap that with the coronary syndrome symptoms. So ST segment. So your ST segment should be isoelectric. So you want a QR, and you want this section here, your ST, to be isoelectric, with what the rest of the weight or rest of your EKG should doing. You should have your T wave, and again, isoelectric. You want your ST segment to match up with everything else. If you have depression with T wave inversion, so if you're looking at ST depression with T wave inversion, and you'll notice how this ST segment is lower than the isoelectric line, hence depression. You're probably looking at some ischemia, which is one of the first signs that there might be issues with blood flow. And for all intents and purposes, we're just assuming it's a blood flow issue moving forward. Yes, there were other ones, and that's why I made mention. Now, if you wind up with ST elevation, either with or without T wave inversion, that's likely a sign of injury. And so your injury is going to be your second stage. And so that's a worsening. You're really, really affecting the cell's ability to repolarize, hence the reason it's taking longer. Your isoelectric line has been elevated. That lack of blood flow is affecting your T waves as well. So that's injury. You're starting to have some cell damage, but it's still reversible. T waves. T waves should actually not be symmetrical. They're not a perfect even lump like that, kind of like a P wave would be. It's not that. It's actually more of a system looking like that is what actually true T waves should look like. Rarely do we sit down and really analyze them that closely, but now is an appropriate time to do so. If your T wave does look symmetrical, that's a problem. It's actually a sign that there's been some problems going on. Also, your T waves normally should be the same direction as your QRS. So anytime you have a QRS, even if your ST is at the isoelectric line, that's a sign of ischemia. And we talk about flipped T waves. And so whenever someone's looking at, they've got flipped T waves, that's what we're talking about. And it's a sign that the repolarization is going out of sequence, that you're having some kind of issues. And I'm going to go back to the previous slide. Yeah. So flipped T waves are not surprising in things like hypertrophy, or even if you have some coronary syndrome or some coronary artery disease. That's where stress tests are awesome. Think about it. You stress out the heart on an already narrowed vessel. If it starts causing flipped T waves, that's a sign that you may have narrowed vessels. All right, so we'll dig into this a little bit. So your ST changes. I know people have had discussions, you've probably heard it during your career, that it's not pathologic. Or it's not a true MI until it's greater than 2 millimeters. You've probably heard that somewhere before. The truth of the matter is it's not that simple. And so I'm actually going to scratch all that out and say this instead. Elevation of less than 1 millimeter in your limb leads is considered normal. So you can have a little bit of variation there. If those get above 1 millimeter, something's probably going on. Now, your V leads, however, are a slightly different story. And the overall concept is this: you can't rely on ST elevation alone, or even ST depression to tell you if it's an MI or not. You have to put in a lot of different other factors. So the idea would be, if your patient presents with any ACS symptoms, acute coronary syndrome symptoms, it's an MI, period. Until the biomarkers, the symptoms, the EKG, all of it's been put together. You have to have the whole picture. All of it has to be done in their medical history too. Probably put that in there too, history. If you don't have all that, you may go down the wrong pathway. It's entirely possible that the patient may have the right kind of heart where they won't really make any kind of elevations or depressions, but everything else clicks, in which case it's not worth delaying going up. It's only 1 millimeter. That's not enough for me to say this is truly a heart attack, so I'm not going to treat them. You know what I mean? So just keep that in mind, that even a 1 millimeter elevation or depression is worth investigating and overlaying with their symptoms. Okay, that's that part. Other interesting things that can happen though, and I'm going to dig into this a little bit, which is known as strain. Strain is the old term. Hypertrophy is the newer way of phrasing it. And we touched on it a little bit when we were going over the hypertrophy stuff earlier and how to evaluate that. But what happens is, due to that increased muscle size, that depth that it now has, it is going to create difficulty when that muscle tries to work harder, when it tries to get the oxygen where it needs to be. Now that can be just at a resting heart rate, and then obviously even worse when you start to stress or strain the heart through activity. The things I want you to take away from this is, one, strain means hypertrophy is what you're looking at there. Two, think about the leads and what they do. It is not surprising that if a patient has right ventricular hypertrophy, that the V1 through V3 can have an ST elevation of 2 to 3 millimeters during activity or during stress. Makes sense. Thicker muscle, more difficulty getting the blood flow through. There you go. So for a period of time, it may look like that patient has an MI going on, but if they rest, maybe they get some nitro, it returns back to normal. The other one would be if you're looking at a left ventricular hypertrophy and you start straining them with either tachycardia or work, like a stress test, you may see in the appropriate leads, because you have lateral lead, left ventricle and lateral leads will show depression and T-wave inversion. And that's again related to that same idea of difficulty getting blood flow where it needs to be and affecting repolarization. Reciprocal changes, I'm not going to, there'll be much more depth in this, but it's the idea that looking at the heart from a different angle and seeing the same effects. And that one's a little tricky. We'll spend quite a bit of time on that as we go forward. The hint I will give you is these inversion, the ST depression with T-wave inversion, looks similar to a reciprocal change, and that's why we're mentioning it here. All right, so example time. We always love examples. Examples of ischemic changes. The big thing for anything that we do when we're looking at changes is that it needs to be in two contiguous leads, ones that are side by side in the same area. If you just have it in one lead, that's probably a fluke. It may just be lead placement. If it's in 2 and or 3 leads, it really sells that picture or sells that idea. So let's talk about ST segment stuff first. And so you have ST elevation, which essentially equals injury. And that's kind of your second stage. And then you have ST depression, which equals ischemia, which is your first stage. And both of them are still reversible if you do things like, get a stent thrown in them, things of that nature. What I want you to really focus on is just how the T wave can look with those different types of elevations that go on. And the same thing here, this one had so these have, the T wave itself is up, that one's upright, flat, and then inverted. The T wave is inverted on this one because it comes back down below that isoelectric line. For here, the T wave is up, inverted, just a little bit up, and this one is inverted here. So, speaking of T waves, what do we got here? So a tall peaked T wave is going to be a sign of hyperkalemia, so high potassium. You may also see it with early MI, which is why we're talking about it here, and in left ventricular hypertrophy and left bundle branch block. So again, and all of those make sense in terms of affecting the way repolarization is done. But yeah, just nice tall peaked T waves throughout. Even if you have an inverted QRS, like in this one, you can still have a tall peaked T wave. And again, the QRS and the T wave are not going the same direction. Big sign that there's a repolarization issue. It's peaked as well, just one more sign. That's probably your left bundle branch block here. All right, and then as for inverted T waves, those guys are usually signs of ischemia. You could also see it in left ventricular hypertrophy, intraventricular conduction delay, or in a good old-fashioned pacer, if they've got a pacemaker. Your Q wave So Q waves are really, really tricky. Very tricky. I've got a whole slide set aside for that. But what I want you to keep in mind is two different types. And so there's the deep Q wave with an inverted T, and Q wave with loss of your R wave. So loss of your R wave, inverted T. So with this one here, what we're looking at is probably a previous MI. Whereas if you have the loss of the R wave, it's likely a active progressing MI that you're dealing with here. It may also be a cardiomyopathy, some hypertrophy could cause this as well, and even COPD, funny enough. But we'll go more into Q waves, but I just wanted to give you this rough overview of what these different ones do, or what these different things represent. All right, myocardial infarction. I'm actually going to stop here, and we'll pick up in a whole nother section and walk through MIs and what they represent.